Now, please welcome to the stage the CEO of Centene Corporation, Sarah London, in a moderated discussion with Chief Health Officer from Salesforce, Dr. Fatima Paruk.
All right, okay. All right, okay. Return to the Mac.
Wow.
Get on what it is, what it does, what it is, what
Did
it
we
is.
choose
Right.
that?
Sarah, thank you so much for making the time and sitting down with me a little bit today. You have taken on a role as CEO of Centene, Fortune 26 company, earlier this year. I'd love to hear a little bit about you. I'd love to hear a little bit about Centene. So let's start with Centene. Tell me a little bit about the company, and then we'll delve into how you got here.
Sure. So Centene is probably the largest healthcare company a lot of people haven't heard of. When I told my husband that I was taking a job at Centene, he said, "Is that a gum?" And it's partly because we operate under a different brand in every one of the 30 states that we operate in. But Centene is one of the largest managed care organizations in the country. We are the leader in Medicaid. We're the number one provider on the marketplace exchange. And we are one of the fastest growing Medicare Advantage providers. So our population is a lower income, more medically complex population, but we serve more than 26 million Americans.
Wow, impressive. So how'd you get into healthcare?
I got into healthcare actually originally, and interestingly, my introduction into healthcare was really almost through the Medicaid lens. So my second job after college, I was working to support the Harvard Institute for Global Health and work that Paul Farmer was doing in Haiti, and proving out this theory that you could see high quality health outcomes in third world countries. In fact, better health outcomes in third world countries than we were able to produce in the United States. And it was all predicated on the thesis, the proven thesis, that by activating the community and understanding how the community resources can actually support patients, you could drive better health outcomes. So after that, I went to work for an organization called Health Leads, which is one of the earliest models in really systematizing social determinants of health. This is an organization that partnered college students essentially as community health workers with underserved populations in urban communities and connected. So you had Medicaid families who were coming in again and again to the pediatric emergency department with asthma attacks. They were giving the inhaler, they were teaching mom and kiddo how to use it, and it wasn't making any difference. And the reality was they were going home to substandard housing with mildew, and that was what was activating the asthma. And so it was an extension of this concept, but it was where I first saw data, real data, about the idea that what was driving health outcomes was not what the healthcare system was seeing. The healthcare system was seeing the amount of information that was gathered in the context of a doctor's visit, and where physicians were not asking about food insecurity, housing, jobs, heating. Did you have heat in the winter? Because they knew they couldn't do anything about it. So I got really excited about data and the fact that data was going to change how healthcare worked and how we understood effective interventions, and that took me on a journey. I am a huge data geek now, excited about technology. Data is sort of a catalyst for a change in healthcare, and then coming back to Centene and being able to think about how to apply those principles against a platform of 26 million underserved Americans was sort of full circle.
Yeah, that's pretty cool. It's amazing to see the power of the data. I mean, your background is so unique and so different to anybody else in this kind of a role. I think, again, you get this at a whole different level. You know the good, the bad, the ugly, right? Where the data is going to give you the answers
data is the ugly.
that you want to hear, and where the data is just not going to give you the right answers. As you play that forward, how do you use that data to help you make the best possible decisions you can make as you plan to scale Centene?
Yeah, it turns out data is going to be a critical part of the transformation of the organization, and I think the realization of the scaled impact that we can have. So Centene has grown tremendously in the last 25 years, but particularly in the last 7 years. And so we have a very complex organization. I sometimes joke it's a $130 billion startup. And so, thinking about how do we simplify and harmonize that organization, and then how do we show up for our members, and then how do we think about innovation? And interestingly, the through line, and it may be just because that's what I want to hear, but I think data is actually through line to solving all of those things. So we have an extraordinarily complex technology ecosystem, and instead of trying to figure out how to get, 9 different technology platforms all to sit on a single, platform. No big bang has ever worked like that. But if we can actually rely on the data, get the data out of the systems, and think about actually operating on a data layer, it will simplify our business and make us even better at sort of honoring our commitments and being good at sort of the fundamentals. And then behind that, creating a culture in the organization that craves data to help us understand what's going on, to help make us better, and then to help us make decisions and prioritization and trade-off going forward. So there's a really basic piece of the next arc of the organization that will rely on data. And then there's this really exciting piece of what data we have pretty uniquely. And it's the combination of having data on our population, which is underrepresented in almost every data set that is out there for research and for clinical outcomes, as well as the data that is in the organization inherently, but not codified. So who are the community-based organizations in every county that are the best at connecting members to food pantries? Who are the best transportation companies? Who are the best, organizations that can help connect our families to job training or to, low-income housing? And so that kind of data actually exists in the organization, in people's heads and on spreadsheets and sort of in programs in each of the states. And so thinking about how do you actually codify that, collect it, and then start to integrate it so that you understand the impact of drivers of health to outcomes, and then how do you narrow the networks of providers, broadly defined, that can actually drive change?
Those are some really interesting points. As we think about those in your population, again, you've got a very unique population. You have some of the most vulnerable, some of the sickest, some of the people who lack access to care. And in a lot of cases, the data may not even be available today, let alone, thinking about how we leverage this and use this to truly make a difference. What does that look like in terms of your vision for overcoming some of those problems as it relates to access?
Yeah, it's an interesting challenge. And your point about the data, there's so many layers to that, right? I mean, just sort of taking a left turn on the question for a second, there's all of this talk about ethically responsible AI in healthcare, right? And we all know that is correct, and yet you have to hold it up against the reality that those populations are fundamentally underrepresented. The data literally doesn't exist, right? So you can't develop against and search for bias when there is, you can't sort of like point out what the comprehensive data set.
I mean, these people are not represented in the population to begin with. So how do you actually get smarter and make a difference when you're thinking about longitudinal health outcomes?
And that's where I think we sort of have a mandate to actually create that data. And to me, data is the, it's like the high-tech, low-cost intervention, which is really what we need more of in healthcare, and particularly in the Medicaid and the complex populations. The high-tech stuff is exciting, but we can't afford it, right? Data is the lowest cost way to have a huge impact. But relative to access, I think there are basic things, right? So one is making sure that we are very intentionally crafting provider networks that are as broad as possible and that are as diverse as possible, right? Because of the recognition that we want to have, that members respond better to providers who understand where they're coming from, right? And then also really investing to expand provider networks. So we've done a lot to actually fund scholarships in different states where we've got providers we funded scholarships in Georgia with a school of medicine, and they agreed to shorten the program from 4 years to 3 years, with the fourth being actually in-field practice if they would go back and practice in rural Georgia, because there are huge gaps in the provider networks in those areas. So actually putting our dollars into expanding the network, because we know how critical access is, making sure that our employee base is as diverse as our member base, so that our care coordinators and just our call center reps and anyone who's interacting with a member, it shows up with the same level of diversity and understanding of the member base that we're dealing with. And then I think the last question, which is a little bit more provocative, is what does access actually mean, and who can provide care? Yeah. And so we've now proven through COVID that access can happen while you're in your home and a provider is somewhere else. And we've also, I think, proven, although we haven't yet scaled it, that that community health workers, that social workers, that caregivers in the home can be just as effective at addressing health needs. And that is a workforce that has not really been fully mobilized against the broader shortage that we have. And yet those folks are in the community, and they are in the home, and they understand our members and the circumstances that they're dealing with sometimes better than the providers who are an hour away.
Yeah, absolutely. I mean, you've got to leverage what you've got in front of you. And, as you started your answer, you were talking a little bit about making the investment in the data, and that being the lowest barrier to return on investment. I mean, when we talk about health equity, we have a $320 billion problem annually. And that's a number that's put out by Deloitte as it relates to the cost of health inequity. By 2040, that number is supposed to be $1 trillion annually. I mean, it's to your credit to make sure that you're making the investment today to solve for this, and I commend you for what you're doing. When I think about provider representation and ensuring that you're making the investment in providers that look like your patient population, that are there, that have that trusted relationship, I mean, I think that has, again, a huge amount of potential to really make a difference. So I'm very happy to hear about that. I'm very positively reassured. We all know that building great relationships does require trust, and I think you've got a huge opportunity to build that trust and build that relationship, and drive outcomes a little bit differently. That being said, a lot of the outcomes that we are talking about take years to realize. They're not outcomes that are visible sometimes on a quarterly or an annual basis. You're at the helm of a company that values deliverables, and you've got to make sure that you're on track. Are we at odds here when we talk about your ability to deliver value versus the long-term goals of health inequities?
I don't think so. One of the things that I think is sort of magical about Centene and about my job is that providing value to members provides value to shareholders. There is no, I say that there is no moral hazard in this job. And it's hard sort of from a distance or outside looking in to know that until you're in the seat. But the reality is that it's not just the nice thing to do or the right thing to do to invest in closing the gap of health inequity. The math actually works. It is fundamentally how you change health outcomes, particularly in our populations. And the reality is it's true across all segments, but it is more true within the Medicaid Marketplace and Medicare and DSNP population. So if we have started to collect, there is sort of broadly data on this, but we see it very clearly in our data. So if you look at members who screen positive for a driver of health, so food insecurity, access to transportation, housing, education, childcare, there is a 20% delta in the PMPM of those members. And so what you're talking about is the idea that if you invest in the right place, and we're essentially largely extensions of the government, right? We are stewards of taxpayer dollars, and we are asked to take those dollars and allocate them in a way that ensures access to high quality, affordable health care, but also drives high quality, affordable outcomes. And so we're in a position where we should be allocating dollars wherever it takes and wherever we should in order to get to those outcomes. And when you look at the investments in those drivers of health, they fundamentally move the needle. And in fact, we do this we have 30 different states that sort of operate like petri dishes. So they are off doing healthy food drives, and they're out, investing in vans for community organizations that deliver diapers and formula to Medicaid moms who are homebound. They're investing in scholarships, and we measure the impact of all of those investments, and you absolutely see the differential in terms of the health outcome, because we know that if you're making a trade-off between filling a prescription and buying food, and you buy the food, you're not adherent to your medications. Absolutely. And we all know that drives sort of further utilization and negative health outcomes. So the data shows that this works, and what's exciting is that I think it's starting to be recognized more broadly in the industry. And so here in Nevada, I'm told that's how you say Nevada, by our team in Nevada. The Medicaid program, I think, has done something very enlightened, where if you are as an MCO, if you are in a payback position, they actually allow you to take some of those dollars and invest them directly in the community. And their theory is you understand what resources in the community are going to have the greatest impact with these dollars, and we understand that if you invest them in the right way, we're going to get better health outcomes within our Medicaid state budget. And so North Carolina is another example of a state that has been doing a lot of work on in the investment map around sort of this community network. And the theory makes sense, right? If you think about all the work that over the last decade we've done from a traditional provider perspective to say who are the highest quality providers, let's narrow the network and make sure that our members have enduring relationships with them. Why wouldn't we do the same thing within the context of a community network that's supporting all of those, the factors that end up influencing 80% of the outcomes?
Impressive. I mean, again, your approach is very innovative. I mean, it's flexible and it works, and I think you're showing that innovation doesn't necessarily have to be expensive. But we're in uncertain times. So given the current economic climate, how do you plan to sustain innovation and continue to grow the business?
Well, it goes back to what you just said, which is innovation doesn't have to be big. It doesn't have to be expensive. But regardless of the economic times, it has to be part of the plan, right? You have to reserve bandwidth for it. You have to reserve investment for it. And so, I think we're in a nice position where, again, a lot of the innovation that we're driving is low-cost innovation, and then gathering the data that will help us understand which one of these ideas has the biggest impact, and then how do we scale that. And I think, again, the imperative becomes even greater because of the economic environment. And we've got a history as an industry of actually innovating coming out of recessions. Yes. If you look at what happened with enhanced advanced premium tax credits, that's arguably sort of a direct result of the pandemic, and what that has done to solidify marketplace as a vehicle going forward in terms of long-term industry transformation, I think there's something really interesting there. So just making sure that you don't put it to the side because you're trying to make sure you're making your numbers every quarter, because without those seeds being planted, you end up being behind when you come out of it.
Sarah, we're already out of time. Thank you so much for sharing your pearls of wisdom, your vision. I am so excited for you to be at the helm and to really be making the difference and innovating in the way that you have, and being able to show that it doesn't have to be expensive, and it certainly leads to more equitable outcomes. Congratulations. Thank you so much.
Thank you.
Really appreciate it.
Thank you, Sarah and Fatima. This concludes today's main stage sessions.